So I'm going to bring up the rear here, so to speak, and talk about something that might be a little more familiar with some of our non-surgical colleagues in the room, but also kind of share with you a little bit about kind of what our approach is to what is become known as a pulmonary valve sparing approach, the Tetralogy of Fallot. I'll try switching this one here. Unfortunately, I don't have any conflicts of interest yet in my career. But in terms of a roadmap here, I'm going to talk a little bit about what are the surgical options for Tetralogy of Fallot in general. I think it's probably well known to the majority of folks in this room that the gold standard in surgery for Tetralogy of Fallot has always been a repair with a transannular patch. Within the past 10 to 15 years within our field, there's been an emerging emphasis toward trying to spare the pulmonary valve during these repairs. And so I'll show with you a variety of different techniques that we use with that, try and continue to dazzle you with some cartoons and intraoperative photos. And then I'll also provide some recommendations for the different repair techniques when we're employing those, and then finally finish up with what we're left with some alternatives to this when it doesn't seem feasible. What I'm not going to talk about is any of RVOT stenting procedures, percutaneous pulmonary valve, or catheter-based procedures in this area. So I think we all know that Tetralogy of Fallot really is a multi-level RVOT process, and we're really dealing with obstruction at the supravalvular area, valvular and subvalvular areas. And with these, there are a variety of different surgical techniques that we use to address the obstructions in these areas. In the supravalvular area, we're pretty much talking about the MPA and branch pulmonary arteries in terms of doing some sort of a pulmonary arterioplasty, depending on the extent of hypoplasia of these structures. At the valvular level, this is where we're really talking about, is this valve one that has anatomy and architecture that is appropriate and deemed suitable for a pulmonary valve sparing approach, or is this something that's just not salvageable in the case where we have to do a transannular patch to open up the RVOT, plus or minus a monocusp, which I'll talk with you about shortly. And then in the subvalvular area, it's always important to resect any obstructing RVOT muscle bundles or anything in this area too. So I think this area is one that is safe to say is a continued area of debate. I haven't been to a national meeting in the past 8 years or so where this isn't a topic of considerable debate, and a lot of my more senior colleagues have a lot of very passionate perspectives on what they think that should be done in terms of approaches. Giovanni Stelline is one of these folks, and he provided a nice review back in 2016 where he talked really about their approach in Padua to doing the pulmonary valve sparing techniques. And I like this article because it does provide a lot of nice pictures in terms of the different techniques. This picture here essentially shows a bicuspid valve here where you can see there in figure B, they're doing commissurotomies to open up the valve orifice more, and then followed by balloon dilation. And I think with all of our pulmonary valve sparing techniques, this is kind of a central theme. This is done in almost all of the variety of different techniques there, and I'll show you some more pictures of this later. These are some more exotic techniques that he's described in terms of trying to increase not only the size of the annulus, but also the size and height of the existing pulmonary valve leaflets. This here is showing some delamination and also addition of some depth of a shallow cusp using some autologous pericardial patches. He provides this here to kind of show their general strategy and approach to valve preservation and repair techniques based upon valve size and Z-score. And you can see initially pretty much valve delamination is something they generally do despite Z-score size for anything that's pretty much a Z-score of less than -3. And then you can see their general strategy here. Perhaps probably a little bit more straightforward approach, and one that I think we use here, and one that in my training up in Boston, I think this is kind of the general approach to their technique as well. But Emil described this in an updated review in the Annals in 2017. This year, or 2015, this generally shows that for all cases, when you're talking about doing a pulmonary valve sparing approach, you have to do a complete infundibular muscle resection, pulmonary valve commissurotomies like were displayed in those pictures previously, as well as augmenting and doing a pulmonary arterioplasty of some sort, usually along the MPA. This here shows kind of our general strategy. I know we can talk some more and debate about a transatrial versus a transatrial transpulmonary approach versus doing a limited infundibulotomy. This picture here kind of shows kind of the general strategy there to orient everybody. This is the head here, this is the feet here, this is an MPA with the longitudinal arteriotomy, and then this is a limited infundibulotomy right beneath the pulmonary valve annulus. This image here is looking back through the MPA at the pulmonary valve, and you can see the commissurotomy is being performed here all the way back to the pulmonary valve annulus. So for cases where pulmonary stenosis is mild to moderate, the simplest technique is to do the commissurotomies and release any other fibrous attachments there, and then resize the valve using a Hager dilator. If at that point we're still not successful at getting back to 1 to 2 millimeters of the normal pulmonary valve orifice for the child's size, there's some additional techniques. So for moderate pulmonary valve stenosis, this is where we're talking about adding in the intraoperative pulmonary valve dilation, balloon valve dilation. And I think this is an important thing that we found, as opposed to just ramming in a bunch of different Hager dilators. The nice thing about using the balloon pulmonary valve dilation is that it really provides a radial transmission of the stress across the entire annulus. Now, there are different techniques to doing this. I know Emil describes doing hand insufflation here and monitoring the valve leaflets in the annulus visually and watching for that point where the valve leaflets are maximally stretched. The annulus is maximally stretched to where if you start to see any tearing of the pulmonary valve leaflet, you stop, and then you serially dilate these with balloons. In my training, we would dilate and use the balloon dilating up to about 120% of the annulus, and that was kind of our technique. Either way, this is a pictorial of that with the balloon being passed from the balloon being passed from the RV through the pulmonary valve into the MPA and dilating that annulus. This here is an actual photograph of this happening. Just to orient you, the head is now over here and the feet are down here, so this is being passed through the pulmonary valve annulus intraoperatively. So an interesting study that was performed is when I was a fellow up in Boston and presented at the AATS last year by Dr. Amani and Sophie Hofferberth, who's one of the research fellows up there. They looked at the experience up in Boston with doing this pulmonary valve sparing technique. They presented it at the AATS last year and recently published it in earlier this year in the JTCVS. And essentially, as you can see here, they evaluated their experience of the 162 consecutive patients, all under 1 year of age, who underwent the pulmonary valve sparing approach, and they compared these really to those that underwent transannular patch. And with median follow-up of 2.5 years, you can see here that really pretty much what they found was that the pre-op annulus Z-score of -2, almost 2.5, and younger age at surgery were the independent risk factors for reintervention for stenosis. And then when they really looked at the freedom from at least moderate PR, I think this is where the most provocative findings of the study came. They found was 77% at 1 year and 43% at 5 years. I'll show you their curves coming up here. And then when they looked at the impact of this on the RV and RV dimensions, they found that they were not significantly different from those with a matched cohort of patients who underwent the traditional transannular patch repair. So this here is the study here looking, or the figure here showing freedom from moderate or greater pulmonary regurgitation after the pulmonary valve sparing repair. And you can see that I think it was surprising how dramatically it decreased over time, up to 5 years. This here is looking at the proportion or freedom from pulmonary valve reintervention rates, and these are stratified here to your right, or to your left, I guess, by pulmonary valve Z-score, and you can see as the valve became smaller, the risk of reintervention became greater. And then similarly, stratified by age on the right, the younger patients obviously had a higher risk of reintervention over time. This here is a scatter plot showing the indexed RV end diastolic area, comparing the transannular and valve sparing approaches, and you can see there was really no difference. So I think these data were obviously a source of a lot of discussion up in Boston. I know when I was there about what do we do with this now and what's our approach and how are we going to address this. And I think that kind of set the stage for where we are right now. This was a follow-up study that was presented shortly thereafter. This is an experience, again, from Dr. Baird and his group, Dr. Amani. This is looking at the risk of right ventricular outflow reintervention in neonates and infants undergoing Tetralogy of Fallot. You can see this included 101 patients, and this looked at both TET-PS as well as TET-PA. And you can see that, and I'll show you in the curves here, that surgical reintervention was really earlier than catheter-based reintervention for those folks who had RV to PA conduits placed, as opposed to transannular patches for the TET-PA group, and then there was really no overall difference in RVOT reintervention rates for the TET-PS patients. They did find, as you'll see, that lower birth weight patients who underwent a valve-sparing approach, they recapitulated the results of the former study I showed you, that they showed that those patients had a higher risk of surgical reintervention. So just looking at their figures here, this is freedom from overall reintervention, catheter-based versus surgical-based reintervention for all patients, and you can see that there was a higher risk of needing a catheter-based reintervention over time compared to a surgical reintervention. These here show the same freedom from catheter-based and surgical-based reinterventions on your left and right, stratified by transannular patch or valve sparing, and you can see there was really no difference in these patients here. And then this graph here shows the TET-PA group, and you can see on your figure to the right that really there was a significant difference in terms of needing an early surgical reintervention for those patients undergoing a TET repair with the RV to PA conduit versus those undergoing a transannular patch. And then finally, this here is showing the impact of size. As you can see, the patients that are smaller than 3 kilos had a higher risk of needing some sort of surgical reintervention over time. When they looked at this in their multivariable analysis, you can see I highlighted there at the bottom that there was a interaction between a valve-sparing TET repair as well as birth weight and size, and you can see that smaller babies undergoing the valve-sparing approach had a higher risk, 5.5-fold increased hazard of needing a reintervention. So where does this lead us for all those patients and all those babies who have really small annulus or valves that we don't think might be amenable to any sort of a true pulmonary valve sparing procedure? This leaves us in the area of having to make this transannular incision. You can see here this is what's been done in these cartoons here. Again, heading back to this paper here, Dr. Basha talks a lot about providing, which I thought was a very unique named the V-STAR, the valve-sparing transannular reconstruction, which essentially is a technique where you do preserve the majority of the pulmonary valve, and you can see here that on the leftmost cartoon, you can see the transannular incision through the anterior leaflet of the pulmonary valve. The remainder of the pulmonary valve is left intact. The commissures are opened all the way, and the leaflets are thinned out. And then, as you can see in the middle figure here, a monocuss patch is tailored and used and sutured into place here, thereby preserving a pulmonary valve, but making it larger. And then there's an RVOT transannular patch that's sewn over the top of that. This is a little bit easier figure, I think, to appreciate that. This is the monocuss valve leaflet that's being sewn in there to the existing pulmonary valve. And then this is the overlying transannular patch that's being sewn there. looking at the results here, you can see on long-term follow-up here, there's a fairly high percentage of these patients undergoing this type of repair that do have severe PR over time. But when you compare that to those undergoing a transannular patch, it's not perfect, but it's better than a transannular patch alone. And you can see, I think here, that I think we all appreciate that the monocuss works early, and then it tends to fail up over time. So to summarize, I think, optimal surgical approach for the pulmonary valve and tetralogy of Fallot remains an issue of continued debate. Valve sparing approaches to TET repair are feasible in all age groups. I think we've shown that. As the Boston group has shown, that young age and low weight and valve sparing TET patients, those are the ones that are at high risk for needing reinterventions down the road. And I think emerging data is really going to suggest an expanded role for the transannular patch or these valve sparing reconstructive techniques in high risk tetralogy of Fallot groups. Thanks.